problem? Okay, anyway, I thank Louis inviting me for this meeting. I enjoy a lot because, you know, we discuss between us. Yeah. It's a free discussion. Although I was asked to talk about the pediatric dural AV fistula, we have two options. Either we discuss the pediatric dural fistula from my point of view, or we will discuss something little more discussable or disputable, which is the conceptual treatment for the bifurcation aneurysm, which is still in question. But nonetheless, I will begin with the dural stuff, right? Okay, why this topic was chosen is that after a long period of time, trying to treat the vascular malformations in the kids, I decided to look at what I did in the past, and then if there is anything that I can clarify in my mind, because recently we stumbled upon some very strange dural AV fistula for a so-called embryonic sinuses. Here is the embryonic tentorial sinuses. Although the patient is not a kid, but nonetheless, it has to be a congenital because it happens on a congenital or a embryonic dural sinuses. The second thing was that we saw more and more incidental so-called dural AV fistula in young patients. As you see here, the patient was studied because of a facial venous malformation in whom we discovered a superior pituitary sinus dural AV fistula. She was young, and then over time, from 2010 to 2018, there was a little bit of progression of the fistula. And also the feeder type has changed. There was a feeder coming from the middle meningeal artery. They disappeared, and then it was taken over by the dural branches of the internal carotid artery. We had to treat the patient in 2018 because she wanted to go into the aviation business, and for the aviation business for her, it was a must not to have any vascular malformation in the brain, and we did the treatment. The third thing, but I've seen this, for example, anterior cranial fossa dural AV fistula in a patient that I treated for a left ICA bifurcation aneurysm. But over the 12 years that I followed, the dural fistula of the anterior cranial fossa did not change at all. Therefore, well, I said there was something strange about this stuff, and let's try to understand what was available in our data. Okay. We know that they may present with a cardiac failure, seizures, developmental delay or arrest or microcrania, or sometimes the mother hears the bruit while she was holding the kid, etc., etc. This is well known. But we have to know that since the brain is developing in a kid, the high pressure of the brain venous system will cause a destruction of the so-called venous border zone between the pile veins, small pile veins, and then the medullary veins. Therefore, we need to do something, as you see here, because after a while, the destruction becomes evident, and then whatever we do is not going to help the kid to have a normal neurological life. We also know that those high pressure, high venous pressure related calcifications can occur throughout the treatment, because in some dural fistula of the kids, it takes time. It's a difficult business, and then it takes time, and then they may develop during the treatment period. Well, you know, this classification of the pediatric dural vascular malformation is done by Pierre Legenias in 1996. And then they decided to have a type 1, type 2, type 3, but this classification does not help us the way that we do the treatment in the pediatric dural fistula. That's why because the same presentation may be related to a single hole fistula of the cavernous sinus, or you may have a nidus type dural vascular malformation draining into the cavernous sinus plus the superior ophthalmic vein. Therefore, we got to come up with something with it which might be interesting for the treatment point of view. Here, it's the IRNI point of view. There are parameters that we should consider during or before planning the treatment of the dural fistula in the pediatric population. If, first of all, the patient has a oligo hold, meaning that the number of holes are limited, let's say less than 5, or there are multiple holes that one cannot count, or the fistula has a nidus type. There is a nidus type, an AVM type malformation within the leaves of the dura, then it drains into a dural sinuses. And one of the most important thing into all that business is that the so-called drained dural sinuses is a functional venous structure for the brain drainage, or it's a non-functional, unfunctional structure that can be sacrificed. As Jack mentioned about, for example, the straight sinus or the Falsen sinus of the kids. Okay, let's go. What I try to say, the oligo hole AVSHUNTS, right? With the functional or non-functional dural sinuses. Here is a kid, a 1-year-old boy with microcrania, brew, and then the trill over the right side of the neck. And when you do the angiography, you see that the drainage of the brain is toward the left-sided lateral sinus. There is no feeling of the distal part of the right transverse sinus. And then when you look at the common carotid injection on the left side, you see that there is a dural branch coming off from the occipital artery, passing through all the posterior fossa, reaching the sigmoid sinus jugular bulb junction, feeding a fistula. The very same patient, the right vert injection now shows another hole, which is the distal part of the sigmoid sinus, also sigmoid sinus jugular vein fistula. But when you do the occipital artery injection, you see that there is a large, very large direct AV fistula of the sigmoid sinus. Therefore, it's an oligo hole dural fistula that you need to treat. The treatment is done through the flow arrest with the double lumen balloon, and then we injected onyx. The reason that I took onyx here was that because I wanted to close the single hole fistula, but also to the distal sigmoid sinus jugular vein junction fistula at the same sitting. That was the reason for me that I took a onyx here. And you see, it's the pre-embolization, pardon, I'm going wrong way. Okay, this is the after the treatment. And 1-year control angiography clearly shows that now the brain is drained toward the left lateral sinus jugular vein system. There is nothing wrong with the deep venous system. Another patient with oligo hole AV fistula is a 2-year-old boy with the Hirschsprung disease, for which he went through several abdominal operations. But at the age of 2-year-old, he was found to have a rather microcrania, and then there is a brew within the brain, and then the prominent facial veins. That's why they did an MR, and then they found that both lateral sinuses were malformed, and also you see that there are some very large pile veins on the left side or the left side of the hemisphere. And then the angiography showed bilateral dural AV fistula on a lateral sinus, which were occluded, total occluded on the left side. Then the drainage was through a labbe. On the right side, there was a continuation of the sinus toward the superior sagittal sinus. It was a single hole fistula when you do the microcatheter injection, you see that there is a direct communication between the dural artery and then the dural sinus. and then it was treated with a liquid embolic agent with detachable microcatheter. Here you see immediately after the treatment, the brain is drained normally toward it's a rostral type drainage, because all the pile veins coming through the superficial sylvian system, then the deep sylvian system, then goes through the either cavernous sinus, pterygoid plexus, or superior-ophthalmic vein outlet. First control angiography clearly shows that the same thing. It was a permanent occlusion, but also the drainage was antrihuman normal, meaning that there was a rostral drainage of the normal brain. Okay, let's go. Multiple hole shunts is another story. Here you have a 1 month old baby, and then she was presenting with from the birth, right? It took them for a while to discover, and then at the age of 1 month, she was referred to us, and then you see there was a very prominent dural superior sagittal sinus, right? But the brain looked normal. When we did the angiography, there was a bilateral meningeal supply. Also, there are several vessels coming off from the artery. I have no idea how many holes there were here. There is only one, especially, for example, at the origin of the foramen cecum, led by the ophthalmic artery going all the way up. Therefore, we decided to do the treatment. First of all, we went through the left middle meningeal. We did here, we decided that the superior sagittal sinus, especially its anterior half, was not functional for the brain, right? And that's why we not only filled the AV fistula, but also we tried to fill the superior sagittal sinus totally down to the foramen cecum, where there was another fistula coming from the ophthalmic artery. And then we went to the right side, and then the right side showed that there is still some remnant. And then from right side, we did another injection. We filled the rest of the superior sagittal sinus. And then at the end of the injection, and then we found that it was a normal, so-called. There was no more filling of the AV fistula. The postoperative period complicated with a seizure, which lasted for about a week. And then we found that there was a hematoma on the postcentral gyrus on the left side, but she recovered very well. And then when we did the control angiography a year later, she has a beautiful, normal looking angiography. What was interesting in that, when you look at the lateral view, now you see that not only the deep venous system is filled, sinus rectus or straight sinus is fit, but now there is a beautiful inferior sagittal sinus, which is draining the brain beautifully, okay? Then this was an example for a multiple hole with non-functional dural sinus. Another one, a 17-year-old male, he has always complained about the fatigue, and then there was an incredible bruise, and then in whom the MR angiography and MR showed then abnormal vessels of the occipital region fed by both occipital artery. And then when we did the angiography, what we found was that there was a multiple hole dural AV fistula next to the so-called functional occipital sinus. Okay, we decided to do the treatment through right occipital artery with a dural branch. As you see here, the lower part, there is we were now within the dural branch, but we decided to protect the torcular herophily and the junction, the right sigmoid sinus jugular vein junction, by inflating the balloon. I used a Copernic RC 8x80, inflated and then injected through the occipital artery. And now you see that the progression of the embolization. Now we fill all the feeders, all the holes, but also a para-occipital sinus abnormal dural venous structure. And after the embolization, everything looks clean. And then the kid or the young boy is cured, okay? Now, the last one is a nidus type AV shunt with either functional dural sinus or non-functional dural sinus. Here is the example. It's an 11-year-old girl with exophthalmos, right? You see the right eye, and then the CT shows that there is a dysplasia of the right sphenoid wing, plus an abnormal vascular structure. It was thought to be a venous malformation rather than arteriovenous malformation, but angiography showed that, let me come here, there was a beautiful posterior fossa developmental venous anomaly draining all the cerebellar hemisphere into a ependymal venous structure, but also, oops, and then when you do it's a left internal carotid, there's little something, pardon, right internal carotid, little something, but when you do the right external, you see there are two AV malformation, dural AV malformation, one on the lateral sinus, the other one, which is asymptomatic, by the way. The other one was the dural vascular malformation of so-called, very probably, sphenoid sinus, right? And then what we did, here you see the nidus type of the dural vascular malformation. This is the vaso-CT that beautifully shows that the vascular malformation is indeed dural, and then drains into the superior-ophthalmic vein as well as the cavernous sinus. But since the cavernous sinus connection was occluded, she became symptomatic. This is clearly, it's a fusion of the angiography with the MR that also shows that the fistula was on the sphenoid wing within the layers of the dura. She was treated through a transvenous plus transarterial approach. I put coil within the transvenous part first, and then I injected onyx in order to completely close the AV malformation of the dura. After having seen the complete occlusion, then decided to do the, although asymptomatic, the lateral sinus dural malformation. I want to show this because it shows that the malformation was indeed the layers of the tentorium, right? And that's why I call it the nidus type dural malformation. This was the couple of days after the intervention. As far as the interventions are concerned, now here are our goals. We need to close all AV shunts plus the unnecessary or unfunctional venous pouch. We should avoid the partial treatment, because if we do partial treatment, the vascular malformation becomes more and more complicated and difficult to treat. We should preserve the normal venous drainage of the brain, because otherwise there is no reason for the treatment. But also we should try to preserve the sinus only if it is functional. If it's not functional, do not bother yourself to try to preserve the sinus. But meanwhile, please try to do a complete injection of liquid in order to close all feeders. And then even if you don't see anything, you should keep injecting until you see the reflux over the cast that you created within the external carotid artery. Okay, I thank you for the confusion that I caused into your minds. Thank you.